Good morning. Welcome to the weekly media briefing for COVID-19. I'm Carrie Schurig, the Public Information Officer for the Shasta County Health and Human Services Agency. We'll start with the numbers. As of yesterday, we've had 8,463 confirmed cases, including 43 from Sunday and 152 from Monday. We've done 110,765 negative tests for a total of 119,228 tests. We have approximately 549 active cases and 7,835 people who have been released from isolation to date. That means that they were positive but are now no longer considered infectious. We've got 45 people hospitalized, including 10 in the intensive care unit. We have an available regional ICU capacity of 29.8%, and we have had 79 people who have died from COVID in Shasta County. With us today, we have Robin Schurig. She's the director of the Public Health Branch of the Health and Human Services Agency. Dr. Karen Ramstrom is the Shasta County Health Officer. We've got Robert Folden from Mercy Medical Center, Reading, Dean Germano from Shasta Community Health Center, and Mark Mitchelson from Shasta Regional Medical Center. Robin or Karen, do you want to start us off today?
Yeah, I can start. This is Robin. I just want to review the latest data that the state uses to determine both our tier assignment as well as eligibility for the regional stay-at-home order. So for the tier assignment, both our case rate and test positivity had been decreasing for a couple of weeks in a row. We were headed in the right direction, but with the latest data that just came out yesterday, both of those metrics increased. Our case rate increased from 29.9 to 34.1 cases per day per 100,000 population. And our test positivity increased from 6.3 to 7.6%. So our test positivity still puts us in the red tier, but our case rate is well within the purple tier. We would need our case rate to decrease to no more than 7 cases per day per 100,000 population in order to qualify for the red tier. And then, as Carrie mentioned, as for the regional stay-at-home order, our latest ICU availability for the region is 29.8%. So since it's higher than 15%, we don't qualify for the regional stay-at-home order. So that's good news, but cases are starting to creep up. And we're also still waiting to see if we'll have a peak in cases as a result of Christmas and New Year's. Historically, we have seen each peak in cases be followed by a peak in hospitalizations and then followed by an increase in deaths. There was a small peak in cases in late December, so we are expecting to see a small peak in hospitalizations as well, either this week or next week. And as far as deaths, we've actually seen a steady rise in deaths from late October through early December, and we expect to see that continue to rise. There is a delay in reporting deaths as compared to cases and hospitalizations because we wait until the death certificates are finalized before we report a death as having been caused by COVID. But we do have a number of deaths that happened in December and in early January that are pending, so they could end up being COVID deaths. So what all of this tells us is that we're doing better than the rest of the state in terms of ICU capacity, but we still have a ways to go to get out of the purple tier. So we really need people to continue masking, distancing, avoiding gatherings, as well as getting tested. Our case rate was actually adjusted up this week because we had lower testing volume than the state average. So it's even more important than ever that we encourage people to go and get tested. That's all I have.
All right, thank you, Robin. Dr. Ramstrom?
Good morning, everybody. So we are in the position of having vaccine, which is fantastic, and a vaccine that we know is effective and safe. And so we are busy making plans and pushing that out to the various groups as indicated by the ACIP at the national level and the state vaccine community advisory committee. And so we're working through those tiers within phase 1A, which is targeting our healthcare personnel as well as residents in long-term care facilities. And so we have a new graphic that's available at shastaready.org that we hope will keep the community informed about what groups we're working on. We have made some steady progress this week. It looks like this, but it's much more colorful on our website. And so we'll continue to check off boxes as we get moving. most of, we're going to be starting, have initiated by the end of the week, we'll have initiated all of Tier 1 and much of Tier 2. So that's all very, very exciting. We're outreaching in the next couple of days to our community clinics in particular to nail down the number of doses that they can use, and so they can start planning and hopefully get that out late this week or early next week. And so we're continuing to receive our allocations. It's a little bit still clunky in terms of anticipating what we're receiving. And that's because part of those doses are redirected to the pharmacy partnership program. Those pharmacists are vaccinating our long-term care facility, healthcare personnel, and residents, which is fantastic because it's protecting our most vulnerable groups in our community, which not only protects those facilities, staff, and residents, but it's also unburdens our healthcare system too and keeps people healthy. So that's kind of where we are. We have several partnerships in the works to get people vaccinated. We're working closely with Shasta Community Health Center. They started vaccinating today, and we're sort of getting our processes down. So very appreciative of that partnership. Hill Country is going to be helping to vaccinate certain groups for us later this week. And we just spoke this morning with Safeway, and they are a new partner. We're going to be able to start lining certain groups up to go get vaccinated as soon as we get them approved by the state. So happy to answer questions, but moving in the right direction. Not as fast as we'd like, but I think at a pretty good clip. And so we're expecting this to really pick up, especially in the next couple weeks.
All right, thank you, Dr. Ramstrom. Do any of our healthcare partners have anything they'd like to share before we open to media questions?
Yeah, just want to say for SRMC, we're really excited. We're starting the second round of injections of Pfizer vaccine for our employees this week, getting a great turnout. So, yeah, staff are very excited to complete the course of the vaccinations. One thing that I just wanted to talk to the community about was even though our staff have been vaccinated, or the majority of them have, the restrictions will continue to be in place. You know, visitor restrictions will continue to be there. Screenings will be there, just because we want to keep everybody safe until the community's gotten a chance to be vaccinated. So I know it's still a little tight if you have a loved one that's in the hospital, but we will continue those restrictions to keep everybody safe until the community's really gotten that availability. So.
Yeah, and I would just echo that, Mark. We're in the same position. So we have many of our second doses being given out to staff and physicians. We were surprised at the response we got. I think we're kind of ahead of where we expected to be. And like any new process, I'm pretty confident that there's a group of employees that are just sort of waiting to see how people do with the second dose. Because, you know, we've heard that the immune response with the second dose is slightly greater than that of the first. So I'm pretty confident we're going to have a second wave of staff who want to start receiving the vaccine. So it's exciting. And then we've also, within Dignity Health or Common Spirit Health, have received our Moderna. So we're also looking at how we can better partner and get that out to the community as well. So we started that conversation yesterday.
Thank you, Robert.
I would just add that I think it was in USA Today, they had a chart looking at vaccine hesitancy and a survey of the population, or a survey of the United States. And it's interesting, from October to December, the number of people who are hesitant to get the vaccine actually shrunk. And I think that was with each passing day. We're now at what, 4.5 million people now have been vaccinated or climbing. I think the confidence level is climbing as well. And like you, Robert, we're still not there amongst my staff, but we did a survey, and I think it's a little dated, goes back a month, but about 70% of my staff are willing to get the shot, and the other 30%, most of them are hesitant. But we expect that to change with each passing day.
All right, thanks everybody. I think we are ready for media questions. Who wants to start us out?
There was an Associated Press story this morning that said that we might receive ICU patients in Northern California shipped up from Southern California in the San Joaquin Valley where they don't have any ICU space. Have you heard anything about that?
Go ahead, Robert.
Well, I read a public health order this morning from the state that came out that basically is telling us that we need to participate, I guess would be the best way to put it. Up to this point, I've been pretty adamant about being careful with our resources because we don't have the sheer number of hospitals here in Northern California to take care of our population. So I feel like, you know, between Shasta Regional and ourselves, we're caring for 20% of the state, 20% of the landmass of the state. We're this huge funnel. So, you know, yes, we certainly want to help where we can help, but at the same time, I don't know if I want to overburden our entire system to the point where now when I have a member of my own community that I can't care for, or worse, I have a trauma that I can't take care of. So I'm hoping there's a reasonable balancing act.
And I would just kind of I would
but
echo those words as well. I mean, between the two hospitals we serve from Eureka to Modoc, and so we're already taking care of majority of COVID cases within those many counties. So we're already really doing our part. So we want to be careful we don't overstretch this.
For the hospitals, are you being told you have to take these patients? And what is our ICU capacity situation now? Maybe Robert, especially with St. Elizabeth, if you can talk about Tehama County as well.
So I'm not going to be able to talk about Tehama County, Mike, just because I personally don't have responsibility. I did talk with a member of the leadership team there last night. They're doing a fabulous job of providing care for Tehama County. With respect to Redding, we're in our usual position. You know, we have a few beds. I think I had 4 ICU beds available this morning. I know we had at least one surgery that's going to require one of those beds, but I remind us, you know, we're so hyper focused on ICU at this time in the media. But the reality is here in Northern California, our ICU capacity, we leverage those beds often. So we always are moving patients through the system from this highest level of care down through lower levels of care. So my ICU capacity is no different today than it is on any other day. It's just that we are doing less of our what we're referring to as elective cases. They're just non-emergent cases. We're doing far less of those today, but my ICU is still full. Our capacity is still, you know, we still have quite a few patients in the hospital. We're just not doing the kind of care that we would normally be doing if we weren't in this pandemic. And then I want to remind folks that we've got plans to surge. So I don't know if our plans for surge, you know, maybe we're fortunate in that we've tested those plans before and we kind of knew where our weak spots were. I can't speak for what's happening in Southern California. I know they're being overwhelmed. I know that there are some amazing hospitals that are being stretched to the envelope. And I have confidence that they've done similar things as we have. You know, part of our system is modeled after a few hospitals in Southern California. So I think when, you know, part of the challenge is when you hear folks say this isn't real, this is very real. It's real enough to the point where this is like the first time in my 33-year history at this hospital that we might be providing some support to our Southern California hospitals. But that's part of what we're expected to do in this EMS system, right? So it takes a village.
So is that a might help out, or is the state telling you you have to help out? Like, is there a number of patients that you have to prepare for, or is it still optional?
I don't know the answer to that yet, Mike. To me, it's an order. So an order says I must comply, or I don't believe it. I don't believe it used the word should, or it used the word must. I think when we're asked for capacity, if we're asked, then there's an expectation. You know, a lot of this relies on social contracts. Again, going back to social contracts, we want to help others, but I'm not giving you a direct answer because I don't have the direct answer. But it is a public health order, and to me, a public health order says I should follow that order. Dr. Ramstrom, I don't know if you have a better answer.
Yeah, I guess the other thing I would just say is there's other aspects to that order, and the idea is to make sure kind of every, hospitals throughout the state are doing what Robert just shared, cutting back on some of those elective procedures in order to accommodate and adjusting based on what the other demands are in the facility, whether it's COVID or otherwise. And so I think that part of the intent of that health officer order was to make sure all hospitals are doing that and cutting back a little bit so that they can take on some share of these COVID patient needs. And so, it's complementary components of that health officer order with the intention of making sure that these patients can be taken care of. We had a call this morning with the Rancho health officers and with our LIMSs and already made just regional EMS partners, and talked a little bit about this. And we think just like we normally do, if a hospital's on advisory and they can't take a patient, they can't take a patient because they don't have space for that patient at that time, or staffing, or whatever it might be. And the needs of Southern California, what naturally would happen is they're going to look for whatever's closest. They're not going to transport a patient, unlikely, I think, from Southern California all the way to Northern California. I mean, they would look sort of within their region to the best of their ability, better for the patient. The bed's going to still be there when they get there, those kinds of things. So I think it's a matter of just making sure that we're all doing what we can. The hospitals and our hospitals have been so proactive about this from the get-go, making sure that they're balancing that. They have to accommodate needs of other patients in terms of these kinds of surgical procedures, but at the same time, when they don't have the capacity, they have to just continue to balance that. So, I think that some parts of the state are having a lot of challenges, and the whole idea is to try and share that burden, across the system.
So Dr. Ramstrom, this thought came to mind. I guess the conflict here is that if we do take ICU patients from other parts of the state and it affects our ratio, doesn't that put potentially our community at even more restrictions? By doing the right thing, are we actually kind of making it more uncomfortable for us community-wide?
Yeah. I guess so.
That was my next question, Dean.
I think that the state has.
Let's think about this logically too, right? So all of us have the ability to surge beyond our normal walls, I'll say. So when you think about a traditional ICU, I think we've all heard many stories that some of these hospitals have gone beyond the traditional walls of the ICU. When we're talking about moving patients from Southern California, or potentially from Southern California to Northern California, that has to be a patient that's relatively stable. So I would venture a guess that the people that we'd likely see are patients that are less critical, very similar to what we have talked about if we ever needed to reopen the alternative care site. So in this case, think of us as an alternative care site for Southern California. So I would venture a guess that we're not going to see as many ICU patients as we would other levels of care. It's possible, but patients have to be stable. It has to make sense for them to be moved. And then for the public, I mean, I don't know how many people realize that it's not uncommon for either Shasta Regional or Mercy to get patients from Crescent City or Santa Rosa or clear up in Lakeview, it is not uncommon for patients to be brought to our medical centers for care. So the thought of transferring a patient over a long distance is somewhat routine in healthcare. I move patients to other facilities in the Bay Area, sometimes Southern California, as part of a specialty need. Yes, this is different because we're talking about COVID, we're talking about a pandemic, we're talking about hospitals that have been overwhelmed, but that's why we have this EMS system.
I would say too that our hospitals are more at risk of transmission within our community, to be honest with you, to be impacted by that, because that's where the immediate need is going to arise. And so and that's why, we continue to encourage these prevention measures, because we're improving, but as Robin shared, we're ticking up again. And so we'll see what happens, these post-holiday couple of weeks. And so that's going to be our immediate, I think, are more of a risk to us than this state health officer order, to be honest.
So the patients that could be sent here are not necessarily ICU patients then. That's correct?
I gave you a scenario, Mike. We haven't been contacted, so I don't want somebody reporting out that Mercy Redding is going to start receiving ICU patients from Southern California. What I'm just trying to explain is it's more likely that it would be a less acute patient, because that patient has to be stable, especially if we're talking about a movement from San Diego to Redding, if that was the scenario.
Okay, so if they're not ICU patients, I think kind of what Dean was asking and what I wanted to ask was, then this would not affect our 29.8% ICU capacity availability right now. Then this would not put us into what all the other regions in the state are in right now.
I will say correct. The only impact it could potentially have is that if it prevents me, if I fill other beds within the hospital and I'm not able to move patients now from that higher level of care to a lower level of care like we're used to, that's where we get into what we refer to as a length of stay issue. So as our length of stay goes up, and let's just use the example of if I had to hold patients longer in my ICU, well, that creates a new bottleneck, right? So every action has a reaction.
Gotcha. Okay, thank you.
This afternoon, the Board of Supervisors is going to vote on whether to open up their meetings again to the public in person. Will Health and Human Services have any input into that decision?
They have not asked us for our input. They've asked County Council for what the legal, requirements are and whether it would be legal for them to open it, but they've not asked us to weigh in on the health aspects of it.
Other questions?
Good morning, everyone. This is Anna here from Action News Now. This one, Robin, you mentioned that we saw a late peak in December when it came to cases rising. Would you say that's kind of related to maybe after the Thanksgiving holiday?
That's my best guess, yes, because it was about 2 to 3 weeks after Thanksgiving, I think, is when we started to see that uptick. So yeah, I think that's probably what the root of that peak was.
And then when it comes to testing, I don't know if we've asked this before, but can testing play a role like in helping us shift out of the purple tier and shift back into the red?
Yes, so there's 2 ways that testing can impact our tier assignment. One is the test positivity. And so the more people who are going to get tested on just a routine basis because they're out and about through their jobs or for other reasons interacting with other people, if they're going to get tested regularly, then that increases our testing volume, which would naturally decrease our testing positivity because it's not just sick people who are going to get tested. And then the other way that it can affect our tier assignment is the case rate can be adjusted either up or down based on how much testing is happening here compared to the state average. So I think I mentioned that this most recent data, actually our case rate was adjusted up because we'd had a low testing volume during that time period compared to the state average. So our actual case rate was 30.9, but they adjusted it up to 34.1 because of our low test volume. So if our testing volume was high, they would be adjusting it down instead. So if we were pretty close to the border of the purple and the red, then that could bump us down into the red.
And normally we tend to see like high testing volume within Shasta County. You mentioned we had a lower testing volume. Could this, do we have any reasons or trends behind it? Maybe because of Christmas or anything like that?
Yeah, I think we definitely saw some drop-offs in testing around both Thanksgiving and then Christmas and New Year's. And so, you know, obviously on the holiday itself, the testing sites were closed, but around those dates too, I think people are, you know, just busy with other things, or they may think that the testing sites aren't available and so they don't go and schedule themselves. So yeah, we did definitely see decreases around each of those holidays and how many people were getting tested.
And my other question is, you know, we mentioned last week that we looked like we were going in a good direction on the downward trend, but seeing us go back up a bit, is this kind of frustrating to see, or was this expected?
We were sort of cautious and kind of keeping our eye out for an increase because of the holidays. So I don't think it was completely unexpected, but certainly it's frustrating to see the cases continue to go up.
Yeah, I also wanted to add, Anna, that testing is a key part of our containment strategy, especially as we start to get, you know, to drive our numbers down. The challenge with this infectious disease is that it can be transmitted when people don't have symptoms. And so the whole idea is if people are out and they happen to be because of their job or what have you, having to be around other people, even if they're being careful, I mean, we know that transmission can happen. And so getting tested on a regular basis, even if you don't have symptoms, allows us to identify those individuals who have asymptomatic infection so that they can stop being around other people and spreading this illness, especially within their households. That's where we inevitably see transmission happening if somebody is actually infected. And so that is the reason that there are incentives built into the statewide stay-at-home order to help us to do containment by incentivizing testing, because it can help us to reduce our case rates and reduce transmission and reduce the number of people who are getting sick and in the hospital and dying.
And my follow-up question to either you, Dr. Ramstrom, or Robin, is that for the next couple of weeks, since we just, you know, wrapped up Christmas and New Year's, will public health be just keeping an eye out for those surging cases that we saw like in Halloween and we saw a bit at the end of December?
Yeah, I think we are expecting to see another increase as a result of Christmas and New Year's. So yes, we're just waiting and watching for those so that we're prepared to respond to them when they come.
So we hope that people were careful, you know, and I think more and more people are trying to do the right thing, and we're really appreciative of that. And I think, you know, but this disease is pretty contagious because we have no immunity. It's growing, you know, as more people in our community are affected and as we get vaccine rolled out. But I'm hoping that people were careful. So we'll see. It's got a little bit of a test for our community, but you know, I think more and more people are aware and trying to do the right thing to the best of their abilities. And so we'll watch.
Thank you. Appreciate those answers.
Yeah, any other questions?
Hi there, this is Matt Brannon at the Record Searchlight. I just had a few. Tier 1 says that it includes, Tier 1A for vaccinations includes workers and residents at skilled nursing facilities. So far, have we vaccinated residents or just workers, or one or the other, or have we started vaccinating both yet?
So the pharmacy partnership program rolled out about a week and a half ago or so, and I don't know, you know, I believe they are starting, so they're going facility by facility, vaccinating both workers and residents by facility. And so I'm certain that residents have been vaccinated. We are waiting to get that information because that's a CDC program. The data originally on the number and individuals who are vaccinated goes to CDC, and then it comes to the state. And so we're hoping to have reports on the number of people vaccinated soon from the state on that, but we don't have that information directly right now.
Gotcha. Have we heard anything about or do we know what happens if seniors in assisted living facilities would refuse the vaccine and say they don't want it? Would they lose a chance to get it for many months, or would they be offered other opportunities, or what sort of happens in that situation? Would they be, having to quarantine more than other residents?
So the practices in terms of infection control will not change because no vaccine is 100%, and new people will be coming into the facilities assuming that they're open to new admissions. And so that won't change. And I'm certain, I've been thinking about this as well, like how will we make sure that even new admissions, once the pharmacy partnership's done, all of our healthcare workers and current residents of these facilities are vaccinated, how will we ensure vaccination of new residents moving forward? And so I think that's something to be determined, but we definitely will keep an eye on that and work towards that. I'm just not exactly sure how that's going to happen yet.
Gotcha. Okay. And then I had a similar question for the hospitals. I know that you guys said that you think that more people will start to take the vaccine as they see their coworkers take it. As of right now, what % of workers at each of our hospitals say that they're interested in taking the vaccine?
Well, I'll say at least we did one broadcast survey, and in that one survey, we got about a 62% favorable response.
Yeah, I think based on how many injections we've given versus how many employees we have, we're running about 50 to 60% individuals getting it on the first go around. And like Dean was saying, I think give it after this week when the first round has gotten their second injections, and we'll probably see an uptick in that. I would not be surprised if we got in a compliance of around 70 to 80%.
Yeah, Matt, I think the bigger issue really is around just people like confidence. And there's a smaller group of people that want to see how others do. So again, I'm super hopeful that as we complete the second dose in the first round of employees, we will have more employees that want to take the vaccine. And then we did a methodical, kind of thoughtful rollout in our vaccination strategy. And we did that because we know that people might have a reaction to the vaccine. So the last thing we wanted to do was, give everyone a vaccination at the same time and then find that part of your workforce maybe needs to take a day off. So I know that sounds weird, but we wanted to make sure that we vaccinated over a reasonable time period. And I think, for us, we will have completed round 2 in about a 5-week period, or I should say our first round of 2 vaccinations within about a 5-week period. So I kind of expect a round 2 of employees to take us into February.
Gotcha. Thank you. And I think this is my last question. Similar, I think this might be best for Dr. Ramstrom. In phase 1A for the vaccine, it looks like there's 3 tiers. Do we have an expected date of when we'll be able to finish either the first of those tiers or all of phase 1A? Do we know when we think that'll happen? Or do we have a goal?
Well, we're kind of thinking about it as we're getting through them and starting each group. And I think each of those groups, just sort of as Robert explained, I think people will continue to come up and want vaccination that might not have gotten it earlier. So that's what we're kind of tracking, as we're getting each of these groups started and continuing to make it available to them. So we'll see how that goes. I'm hopeful that we'll move into scheduling, or at least we're trying to identify groups that fit into tier 3, so that we can start reaching out next week and getting people arranged and scheduled depending on what their situation is and where we can get them vaccinated. So we're doing our best, and part of it will depend on our supply, and so we'll see how that goes over the next week or 2 as well. And we'll have to keep going back, as Robert was just explaining. We might have more interest as we continue to move forward. Additional workers may say that they'd also like to get vaccinated later, even though they were in an earlier tier, and we'll want to accommodate them.
Gotcha. And I guess just to I see what you're saying, where it's still a little early to know maybe entirely when we'll be able to get all that done by. But, you know, for at least the first tier of phase 1A, is it more of like a matter of days or a matter of months, or, you know, how, you know, what is sort of the scale?
So tier 1 of phase 1A, we will have initiated every one of those groups by Friday.
And do we know how long it would take to finish that tier?
So I think we'll get through the most of those groups, those who are interested, probably by next week. It depends also on scheduling and availability. So we'll make it available to them, but depending on when staff can be freed up and staggering schedules and those kinds of things. But probably into next week, we will be close to being through all the people who are interested in that tier. But again, people may pop up later who want to get vaccinated.
Gotcha. Okay, thanks. Just trying to get an idea if these tiers are expected to take, you know, a few days to move through each ones, or a few weeks, or a few months, or yeah. Okay.
So I guess I can tell you that there are almost 14,000 healthcare personnel that are credentialed in the county, and in addition to that, in these tiers, you'll see people who are more paraprofessionals who aren't credentialed. So in addition to that 14, it's probably a couple or 3 additional thousand people. It's a lot of people, and so if everybody wanted it, we have to wait until we have that number of doses, and we don't have that supply yet. But if we're starting out with this, about 50 to 70% or so who are interested, you know, that'll go further. So we're probably going to continue to vaccinate people in these tiers for some time as more interest arises and as people are freed up.
I just wanted to add that right now, one of the rate limiting issues is the availability of the vaccine. But the second piece is the availability of personnel to give the vaccine and infrastructure. And I think that, I know my organization, I'm sure the others as well, we're starting to think now, how do we take care of the rest of the community with these issues? Assuming that the vaccine will arrive in quantity sufficient, how do we roll this out? And it's complicated by the fact there's 2 vaccines you have to give and track. So, you know, we're doing this precision bombing thing now with getting to our medical personnel, the tier 1s, nursing homes. But I think the other big challenge that we're going to have to start getting our arms around is, how do we really roll this out to the whole community and do it in a reasonable time frame with sufficient safety, so that we can get to that level of herd immunity sometime, I hope, by the end of the year, if not sooner. Maybe that's a pipe dream, I don't know, but certainly I would love to see that happen. I don't know if anyone else would. Dr. Ramstrom, you have any thoughts on this? But that's in the back of my mind as we work through this.
Yeah, it's in the front of my mind every day. I agree with you 100%. So we have to remember, we've had staff assigned doing case investigation, contact tracing, working with businesses, working with a variety of organizations in health facilities since, you know, March. And we've have hired extra people, most who are part-time, to do this work. And now we have to roll out a vaccine to the whole community. Holy cow. And so, you know, it's a huge task. And so we've had to redirect people and get new processes in place, be on calls every day with the state to see how things are rolling out, how they're managing it, how it's coming to us, the logistics of vaccine handling, where it's going, working with Mercy, the distribution, getting providers signed up. We work with them, then the state approves them. There are so many components to this that, let alone having somebody who can put the vaccine into someone's arm. So there's, you know, that's why this is taking some time to even just figure out our processes, do that outreach, get people signed up. Super, I'm happy to have Shasta Community Health Center, Hill Country. I've had other provider offices reach out to me and say, we're ready when you're ready. And so we're trying to get ready where we can get vaccine out, but again, getting them enrolled, getting them to where they can accept vaccine. And then thinking about, we were talking this morning about, we would like to do some mass vax clinics and plan those and have that in place. So as we're able to push it out to bigger groups of essential workers and the public. But we don't even have a staff who can plan that right now. And so we're trying to figure out how to make that happen. So there's so many pieces to this that we're running it as fast as we can, and very happy this week that we've made some progress through these tiers. Happy to be starting to push out the vaccine to our community clinics next week, and just get it rolling, get it into people's arms and get people protected. And so, but there are a lot of logistical considerations and staffing challenges with this for ourselves and as a community as we think about, as Dean said, rolling this out more broadly.
Thank you for those answers. That's all I had.
Dr. Ramstrom, if there's only a 60 or 70% at best confidence level among healthcare workers in this vaccine, what can be expected of the general public? And if we achieve 70% of the general public vaccinated, is that enough from an epidemiology point of view? Is that enough to insulate the unvaccinated from each other?
Yeah, I think we're going to see interest grow as this goes, as people see more and more people get it. They're healthy. They have, had a reaction that we have with other kinds of vaccines, if anything, sore arm and maybe feeling a little crummy for a day. I think as that happens, it will be more reassuring to more and more people, and more people will get vaccinated. And so I think it's yet to be determined exactly what percentage we need. We're going to have a combination of people who have, and it's going to take time. So my hope is that we'll get to a point where we have enough people vaccinated, and we can actually do disease containment like we normally do, because our numbers will be small. Over time, they'll start to go down as we have more immunity. There's still a lot to learn about these vaccines too. Do they prevent people from infecting other people, or do they just prevent you from getting sick? And so all of those vaccine trials are continuing to do follow-up with people that they vaccinated. And so we're going to continue to learn as we go. And that's also why the prevention measures are still recommended. As we roll this vaccine out, we still need to make sure that we're limiting transmission with all the ways that we've been talking about for months now. And so, I think that we're moving in the right direction. This is very positive. We have some tools now to help us to come out and move in the right direction away from this pandemic and to shift. It's a huge milestone. So we'll learn as we go.
Yeah, Steve, and I want to jump in and emphasize again, we're always reluctant to give a number, right? Because the number we gave you was a response to one survey that we put out. So we're only 3 weeks into this. Maybe we could call this week 4. This is early in the process. So I heard from Mark, you're hearing from me. I think we're excited with the progress that we're getting. But if we have this conversation a month, 2 months from now, I think we'll have a much better picture of where we really are. And the other thing I want to remind people is, I have a pretty big workforce, and we have people who are pregnant right now and they don't want to take the vaccine. But once they have their baby, they'll likely get the vaccine. We have people that are on leaves of absence that are still included in our denominator, but they aren't able to get their vaccination yet. So again, we have this conversation 6-8 weeks from now, we'll be able to give you a much better number as far as where we're at.
All right, thanks, Robert. Any other questions? Okay, thanks everyone for being with us. We will be back again next Wednesday at 11 a.m. Everybody have a safe and healthy week.